So, assalamu alaikum, everybody. My name is Aghiad Alkhachem. I'm a second year medical student, and today we'll be talking about the regulation of volume and ion concentrations in the ECF and ICF. All right, now before we start, you guys should know the rules by now, but you should ask me any question that comes to mind. All right, we have checkpoints, but if you want to stop me, you can stop me and ask. And if you go over the lecture again and you find some difficulties, do contact me on my socials. All right, so it's a pretty simple lecture. You should guess what it's about by the name. You should try to have an understanding of what should come. And yeah, Bismillah. So our objectives for today, they're very simple. Two. So the first one is to describe the sensors and effector systems that are involved in maintaining a constant extracellular osmolality. Okay. The second one is the same one about maintaining a constant extracellular volume. So one is about osmolality and one is about volume. All right. Now let's start with the osmolality. But before we do that, ask why. What's the point of all this? This is the main question in physiology, right? If you ever want to understand physiology, and you're kind of messing up with the details, always ask yourself, okay, why are we doing this? What's the point? You know, this will help you go through physiology, whether it's about renal or anything. Okay, because once you get and grasp the concept and the point of all this, you can try to assume what happens, even if you don't know the knowledge properly. Okay, so it's even a better combo when you know why and you can remember why properly. Okay, so always ask why. And again, we're trying here to maintain osmolality and volume. Okay, you want them to be constant. All right. So, all right, let's start with the details now. So the mechanisms of controlling osmolality and sodium concentration. We have three main ones, okay, as you can see on the screen. You have the osmoreceptor, ADH system, the antidiuretic hormone, the thirst mechanism, pretty simple, and salt hunger mechanism. The latter two are simple, right? It's just the osmoreceptors have a bit of detail on them, right? So let's start with the osmoreceptors. So it increases in osmolality caused normally by increases in sodium. Okay, so the more sodium increases, the more osmolality increases. And associated negative ions like chloride, it stimulates the osmoreceptors. Now, osmoreceptors, okay, receptors receive these ions, they sense these ions, right? And they get stimulated. Now, the stimulation of these osmoreceptors provokes synthesis and release of ADH. All right, so you can kind of guess now what's going to happen, right? Of course, release of ADH in the hypothalamic hypophyseal system. Okay, so now you can tell that, okay, sodium increased, all right, and the negative ions associated with it. Now, what do we want to do? It's becoming hyperosmolar, okay? It's becoming hyperosmolar. We don't want that. That's excessive, okay? So now ADH enhances the permeability of luminal membrane in the late distal tubule and in the collecting duct, which in turn causes more water reabsorption. Right, that's the why here. That's the point. More water reabsorption. All right, water reabsorption with unchanged excretion of Na, unchanged, doesn't affect sodium, ADH. It doesn't affect sodium at all, right? So water reabsorption with unchanged excretion of sodium and other osmotic effective substance dilutes the extracellular fluid, right? The extracellular fluid was hyperosmolar, right? And that is due to the increases in sodium levels and the other negative ions. Now the osmoreceptors sense that, they receive that. These receptors receive that, okay, this information tells us that, okay, it's becoming hyperosmolar. All right, and in turn, through this system, the hypothalamic hypophyseal system, right, ADH is secreted and then enhances the luminal membrane, the distal tubule and collecting duct, so we can absorb more water. Nothing else but water, right? So ADH, only water, okay? And this just shows you can only see H2O here. It increases the water reabsorption, right? Okay, this is the blood, as you can see. So the water moves from the tubular fluid through to the blood eventually. All right, so as you can see, this is just a picture to show you. Dr. Hashim Shams loves to have you understand everything properly, not just have some abstract concept in your head. All right, so this is without ADH, and now you can see this is with ADH. Okay, so this is to enhance water absorption. Okay. Now synthesis and release of ADH. Okay, it is in the posterior pituitary, stored. Now it's synthesized in the hypothalamus. Okay. Now what we really want to know here is the effect of the baroreceptors on the increase of ADH release. So you guys know what baroreceptors are. I want people to answer. We have, I guess, 3 people. So do you guys know what baroreceptors are? I see nobody answering. But okay, baro is pressure, receptor is pressures. Receptor are receptors. So they sense the pressure. Okay. Now what can increase pressure? Increases in blood volume. Right. So the more blood we have, right, the more volume we need to accommodate for, the more pressure there is on the wall. Okay, you guys should remember the baroreceptors from your CVP. Okay. So yeah. So the more the baroreceptors fire that, okay, or the more signals that are sent saying we have too much blood, the lesser the ADH. So consequently, the lesser the ADH, because ADH wants water, but we already have a lot of blood volume. Why add more water to that? This is only going to increase the pressure. Okay. So as you can see here, this is ADH. Always have to orient yourself with these graphs. Okay, plasma osmolality and ADH. As you can see here, the more the plasma osmolality increases, the more ADH increases. Obviously, because too much osmolality, we need ADH to increase the water absorption. We need to be stable here. Okay, and as you can see here, the blood volume, okay, or blood pressure, both of them, they're kind of interchangeable in this case. Okay, so the more blood volume, the lesser the ADH. Why do we need ADH if the blood volume is sufficient? And what reaches extreme measures, obviously there will be no ADH. So yeah, this graph is pretty simple. It just explains the relationship. So hyperosmolar, more ADH. Hypoosmolar, no need for ADH. All right. So with blood volume too. Okay. More blood volume, no ADH, because halas, we already have enough volume. We don't need more water to that. Okay. But blood volume is decreasing. Okay, ADH is released, and it absorbs the water from the tubules. So it's pretty simple. All right, this graph is just to show you that ADH only affects water, as we mentioned, as you can see here, and that graph, yeah. See, it's only H2O. Okay, so electrolytes and the solutes are not excreted. Okay, so total solute excretion remains the same, unchanged. As you can see here, this is basically what the graph is trying to tell you. All right. Now, from its name, antidiuretic hormone or vasopressin, right? It wants to increase the pressure or decrease the osmolality. Okay, so it's synthesized in the hypothalamus, as we mentioned, and so the neural hypophysis or posterior pituitary. Okay, and the releasing stimuli. Okay, osmolarity. Again, we mentioned that. So now more ADH is released, or stretch receptors on low pressure systems. Okay, so the lesser the pressure, the more the ADH. You want to, okay, we need more water to increase the volume. Okay, so if we have too little pressure, ADH is released. Okay, and you can see that by this graph. Okay, when the blood volume is decreasing, ADH is increasing, as you can see here. Okay, so it's pretty simple. And again, it's only water, pure water. Okay. This is just to show you the normal water intake and excretion of adults at room temperature. We have water intake as fluid, food or metabolic water, and you may be confused as to why it is food. We do take water as food with food, but it is insufficient. That's why we need to take it with fluid. Some animals can live purely off of food. I think Dr. Hashim gave us that story of his last year. I don't remember the animal exactly, but that animal can live only off of food, doesn't need to drink water, because it retains sufficient amount of water through food. All right. Now, obviously, that water is lost through the skin, lungs, sweat, stool, urine, mainly urine. This is the main reason. Now, you can imagine that the skin will increase. There's an increase in temperature. Okay. There's more loss here. Okay. You sweat more. Okay. Yeah, sweat. You see, it increased. Okay. It was here around 100. Let me just, all these scribbles. 1 second. Okay. So as you can see in hot weather, sweat releases more water. Okay. So normally it's 100, but when you sweat too much in hot weather, it increases. So yeah, this is the, at room temperature, stable environment, and this is with changes. Okay. So yeah, nothing really more here to say. It's just to show you, okay, if you're losing more water, you need to drink more water. So to accommodate for that total loss, you need to have this at least amount of water intake. When there's hot weather, the room temperature we just talked about, or long and severe work. Okay, so checkpoint. Is everybody okay? Are you guys doing good? All right, cool. All right, good. Okay, now let's move on. Now for thirst, we said 3 mechanisms. So osmoreceptors, ADH system, thirst, and hunger. Okay, thirst and hunger aren't really that difficult. So thirst mechanisms, or the thirst center. Okay, their location, it's in the hypothalamus, and the stimuli for thirst is intracellular dehydration. For example, increased sodium in ECF. Okay, so the more sodium, it gets the body interprets that as we don't have enough water, so you get thirsty, right? So again, has to do with osmolality, right? And this is the threshold for it. Okay, just memorization here. There isn't much to do, and it's logic, thirst. If too much sodium, that's why you get thirsty when, for example, you take too much salt. Eat a salty meal, you become more dehydrated. You want more water. All right. And this is salt hunger, localization again in the hypothalamus. And the stimulus for that is a decrease in sodium in the extracellular fluid, or decrease in blood volume. Because when there's too little sodium, the body interprets that we're not getting nutrition properly. Okay, or there's too little blood volume. Okay, that simulates you eating, so you can produce more blood. Okay, and then here it says that thirst is developed immediately, whereas salt hunger is generated after several hours or days. That's why people die within a much shorter amount of time because of thirst than hunger. Your body is more tolerable to hunger than it is to thirst. Okay, and this shows you that there's too little volume, you die. Okay, and there's too much, that's pathological now, that's edema. Okay, so yeah. Can you guys hear me well before we move on to this part of the lecture? Okay, cool. All right, now we're going to move to control of blood volume. We talked about osmolality. All right, perfect. We talked about osmolality. Now let's talk about blood volume. So there are five main ways. Okay, so pressure diuresis, and it is quantitatively the most important mechanism, and arterial baroreceptors, of course, baroreceptors because blood volume. We've talked about that previously, because the more blood, the more pressure, and the lesser blood, the lesser the pressure. It's a CVP material, but let's revise that. Okay, and then atrial natriuretic peptide. Okay, you can assume if ADH is antidiuretic hormone, then atrial natriuretic peptide wants to release fluid from the name, right? You have aldosterone and ADH again. We've talked about ADH, so let's talk about the rest. Okay, so again, you have to ask yourself why. What's the point? Okay, so the atrial natriuretic peptide wants to get rid of the blood volume, the water. Sorry, excessive water. Okay, that it's you can tell by the name. Natriuretic wants to release the water, excrete it, because there's too much. The body doesn't modulate too little water, it also modulates too much water. Okay, in atrial, because you can, that makes sense because it's released from the atria and ventricles. Okay, aldosterone, we'll talk about aldosterone in a bit. ADH, we've talked about it. Now for the pressure diuresis and the atrial arterial receptors and volume receptors and low pressure system, we've also mentioned them above, but we'll get into more details now. Okay. All right, so changes in blood pressure cause changes in sodium excretions. And there are two mechanisms for that. Okay, so again, changes in blood pressure, they cause changes in sodium excretion. So the more blood and the lesser blood will affect the sodium in different ways. So first, the increased blood pressure augments blood flow in the vasa recta, right? The vessels on the tubules and all of that. You guys should know that from anatomy and everything. And it washes out medullary solutes and reduces interstitial hypertonicity in the medulla. All right. When there's too little hypertonicity, the water doesn't move towards that. Okay. So now we can get rid of the water or absorb the water if we improve the hypertonicity. Okay. And then second, an increase in arterial pressure leads by an unknown mechanism. We still don't know yet, but for some reason, it rapidly decreases the number of apical sodium hydrogen exchangers in the proximal tubule. Okay, again here for pressure diuresis / natriuresis. Okay, so the more pressure there is, the more the blood volume and NA excretion. Logically, okay. So again, more volume, you get rid of that water. Okay, that be with urine volume or excretion of sodium, because it retains the water. Okay, so this graph should summarize all these words simply. Does everyone understand? Okay, I want to see another yes. Okay, cool. It's a pretty simple lecture. It's not really that difficult. You should just understand what's the point, what will happen, Again, physiology is all about asking why and how. Okay, this just shows you the regulation of blood pressure, how it happens within seconds to minutes. Blood pressure falls, sends signals to the arterial pressure receptors that the pressure has decreased. That goes to the medullary centers and sends signals to the sympathetic, increasing sympathetic output and decreasing the parasympathetic. This is more, CVP related, but Dr. Shams loves to have, to paint a full picture when it comes to his lectures. So again, you get constriction. I think I even taught this lecture. So this is all CVP stuff. If you guys need me to explain it more, do message me or contact me, call me, anything. Because this isn't that related to the topic as much as it is related to CVP. Okay, but you guys should know most of that, right? You should be familiar with that. Okay. It's all if you ask yourself, okay, why are we doing this? It'll all be clear. The pressure has fallen, so we need to constrict. We need to increase the pressure because without the pressure, the blood wouldn't move. Okay, and we'll get into more details of what would happen when the blood pressure falls. Okay. Now I know this may seem like a dense slide, but we'll take it shwaya. So now we're going to talk about the natriuretic peptides. We have the atrial and brain natriuretic peptides. We have urodilatin, right? And here, Dr. Shams emphasized that it's more potent than atrial natriuretic peptide for a reason we're going to state right now. You have uroguanilin and guanilin, okay? So I'll read the slide first and then explain everything. So the atrial natriuretic peptide inhibits an ACL and water reabsorption. All right, so secretion. So you guys get the point I've mentioned before. It inhibits water reabsorption because we have too much. We don't only modulate for when we have too little water. We also modulate when there's too much water. Okay, so it inhibits sodium chloride and water reabsorption. All right. So secretion of AMP by the cardiac atria. Okay, so by the atria, atrial natriuretic peptide, and then brain natriuretic peptide is released also by the ventricles. Okay, is stimulated by a rise in blood pressure and an increase in extracellular volume. We have too much blood, too much water, right? We don't want that. Okay, so what would happen? You can kind of assume now the scenario the natriuretic peptides become most useful in when there's too much blood volume, too much water. Okay. Increases in extracellular volume as well. So ANP and BNP reduce blood pressure by decreasing total peripheral resistance and enhancing excretion of sodium chloride and water, as we mentioned. Okay, because it reduces and inhibits the reabsorption, thus enhancing their excretion in urine. Okay, and also here it mentions, it decreases total peripheral resistance because you have too much pressure. All right, so we need to relax so we don't damage the arteries or veins. Okay. They take effect in the medullary portion. Dr. Shams emphasized their location and the importance of their location. All right, so they take effect in the medullary portion of the collecting duct. Okay, and they also inhibit ADH stimulated water reabsorption. They're trying their best to limit the amount of water there is in the body. Because again, if you remember from this slide, this is the normal value. This is what we want. We don't want too much, else there will be edema, excessive water, or too little, so we don't die, obviously. So here ADH comes into play, and here ANP also can come into play with BNP. Okay. So this is basically it for the natriuretic peptides. Okay, they help us excrete salt and water. Okay, while also decreasing the resistance in the arteries. Okay, and they take effect in where? The medullary portion of the collecting duct. Okay, they also inhibit ADH, obviously, because you don't want to blunt the effects of AMPs with the presence of ADH. Because if ADH is trying to retain water and AMP is trying to decrease water, what benefit is that? Okay, so it also inhibits ADH stimulated water reabsorption, and that happens, while reducing the ADH secretion from the posterior pituitary. You guys know the system we talked about, the hypophyseal. What was it called again? Okay, 1 second. Let me just find the name. Hypothalamic hypophyseal system. It gets confusing. Okay, so it inhibits the secretion from the pituitary. All right. So it's synthesized in the hypothalamus and stored in the pituitary, but inhibits, AMP inhibits the release from the pituitary gland. Okay. Is everything good? You guys understand? Yes, I want another yes. Okay. Now on to urodilatin, another natriuretic peptide. They all have one purpose, right? That is get rid of the water. We don't want water. Okay. So urodilatin is secreted by the distal tubule and collecting duct. Now that's a major difference, right? It's not present in systemic circulation. It's in the distal tubule and collecting duct only. This is where it's secreted. Okay. So secretion of urodilatin is stimulated by a rise in blood pressure and increase in extracellular fluid volume. You can kind of understand, what it does by just knowing when it is secreted. And it's secreted when there's too much pressure or volume. Okay. So again, it inhibits salt and water reabsorption across the medullary portion of the collecting duct. Very, very similar to AMPs. Okay. Now urodilatin is a more potent natriuretic and diuretic hormone than AMP. Okay, and what is the reason for that? Okay, it's because it's not present in the systemic circulation. That plays a role because some of the AMPs that enter the kidneys and blood are degraded by the natural endopeptidases, right? And these endopeptidases, these neutral endopeptidases, right? These endopeptidases cannot affect urodilatin, and this is why it is more potent. Okay. Again, synthetic urodilatin can be used in cirrhosis as well. Just keep that in mind. Dr. Hashem didn't really emphasize that, but he put it there, so be careful. So yeah, this is why it's more potent. They both serve the same function, right? Inhibit the absorption of salt and water, AMPs, BMPs, and urodilatin. Why AMP is released from the atrial natriuretic peptide, and BMP, brain natriuretic peptide. I don't know why it's called brain صراحة, but it is from the ventricles. So atria, and then the rest is ventricles. Okay. Again, they act in the medullary portion of the collecting duct, as you can see here. Okay. These are the AMPs and BMPs. Okay. While the urodilatin is secreted and by the distal tubule and the collecting duct as well. Okay. Now on the final one, the natriuretic peptides, uroguanilin and guanilin are produced by neuroendocrine cells in the intestines. So they come from the intestines in response to the oral ingestion of salt. So the body is saying, okay, we're having a lot of salt, we're coming out, we can get rid of it. Okay. So these hormones inhibit salt and water reabsorption again by the kidneys through this system, okay, through this pathway, the activation of membrane-bound guanylyl cyclase receptors, okay, CGMP and everything, okay. So back to the picture, all right. So here he is mentioning the afferent arteriole gets vasodilated, the efferent arteriole gets vasoconstricted, okay. That in turn, if you guys remember the picture, okay, it's sort of like this. Just to give my read lesson, everything. Okay, so this is the afferent and efferent. Okay, the afferent gets dilated and the efferent gets constricted. Okay, and so that in turn increases the glomerular filtration rate and the filtered load. Okay, now we'll get into aldosterone in a bit now, but decreased aldosterone causes decreased NA absorption. So you can kind of assume, okay, aldosterone affects sodium levels. It targets sodium. ADH targets water only. Aldosterone targets sodium. Okay. All right. We'll get more of the details, but you guys good? Another checkpoint. Are you guys okay? Has some memorization. So yeah. I don't want you to guys just ask yes, okay? Please make sure you're good. It's your chance now. All right, cool. So this is the renin angiotensin aldosterone mechanism. Okay, so hyponatremia. What does that mean? Let's see, guys, if you guys are focusing. What does hyponatremia mean? It's pretty simple. Yes, low sodium. All right, so that or reduction in renal perfusion causes the release of renin. Right, it's the renin angiotensin aldosterone system. So renin increases angiotensin too. What does angiotensin do? You can kind of assume what we want here by when renin and angiotensin are released, when there is hyponatremia, right, or reduction in renal perfusion, right? The kidney senses, okay, we don't have much blood now because their perfusion is too little, all right? So that in turn does everything in its capabilities to increase the amount of water and pressure. So we increase pressure by increasing volume and constricting, if you guys remember, okay? So it releases ADH and increases the absorption of water. It causes vasoconstriction and total peripheral resistance because it senses that there's too little blood. We want to increase the pressure for now. That's a very, very important precaution we take. We increase the pressure all right? So the blood can move while also increasing the amount of water we're retaining, okay? And that happens by vasoconstriction and release of ADH. Now, aldosterone, as you guys remember in the previous slide here, okay? When aldosterone is decreased, there's a decrease in sodium. So you can kind of, assume what aldosterone does, can kind of guess, and that is increased sodium. And increasing sodium in turn increases water reabsorption. It follows in the kidneys. And finally, you have thirst. This is the most simple mechanism, like, okay, just drink more if you don't have water, or if there's too little water. Okay, so this is the function of angiotensin 2, and it's stimulated and released due to renin's presence. Okay. Again, this may seem like a dense slide, but we'll take it slowly. Okay, so the renal effects of angiotensin. Now that you guys know what's the goal of angiotensin, what it does, and when it's released, you can understand everything. You guys basically know this. This just has a little bit more detail, but you guys know all of this. Okay, so besides increasing sodium absorption via aldosterone, we've talked about aldosterone, sodium. Okay, angiotensin 2 increases sodium absorption by altering renal hemodynamics, not just through aldosterone only. Okay, so angiotensin 2 constricts the efferent more than the afferent. Okay, again, I'll draw it again. I should have had a picture of it. Okay, so this is the afferent, and then this is the efferent, this is the glomerulus. Okay, so it constricts the efferent more than the afferent. That in turn, right, causes more filtration, and that reduces the hydrostatic pressure in the downstream peritubular capillaries, right? These convoluted capillaries around the tubules. Okay, peritubular capillaries. Now, when decreasing the hydrostatic pressure and also increasing the oncotic pressure, as you will read in a bit, so the increased filtration fraction also increases the protein concentration. This is perfect. Can you guys still hear me with the alarm? All right, how about you stop the recording and we'll cut that bit out, عشان maybe unclear for them, okay? Okay, so after having discussed what the purpose of angiotensin is and when it was released, you guys can have an idea of its function and what it does exactly. All right, we've mentioned them, but we're going to go into more detail as to what they do. So you said they vasodilate the afferent arteriole and constrict the efferent arteriole, right? And that in turn decreases the hydrostatic pressure in the peritubular capillaries, right? The capillaries around the tubules, all right? So when the hydrostatic pressure decreases, right, and the oncotic pressure increases, water goes towards these tubules and is retained. Okay, as you can read here. So the increased filtration fraction also increases the protein concentration in the peritubular capillaries because proteins are not filtered. All right. So the increased filtration fraction also increases the protein concentration in peritubular capillaries and hence increases the oncotic pressure of the peritubular capillaries. Now the changes in each of these stalling forces favor the uptake of reabsorbate from peritubular interstitium into the capillaries. Okay, into the peritubular capillaries. Okay, and hence enhances the reabsorption of sodium and fluid by the proximal tubule. Okay, so when dilating the afferent arteriole, so more blood is coming to the glomerulus and constricting the efferent arteriole, more filtration occurs. When more filtration occurs, okay, the blood in the peritubular capillaries that comes after the efferent becomes hypertonic and it has decreased hydrostatic pressure. Okay, and so now stalling forces favor the uptake of that water, right, and sodium and the fluid. Okay, uptake. Okay, as we have mentioned here. Okay, so angiotensin 2 decreases medullary blood flow through the vasa recta, right, and the low blood flow decreases the medullary washout of sodium and urea. Okay, that process that releases urea in the medullary interstitium. Okay, now angiotensin 2 raises the sensitivity as well and lowers the set point of the tubular glomerular feedback mechanism. So therefore, what would happen is increases in sodium and fluid delivery to the macula densa produces a larger reduction in the glomerular filtration rate. So they all are trying to, increase the water, increase the sodium. We're trying to increase both of these. Once you know the purpose, you can kind of guess what it does. So that's why you should always ask yourself why. What is the point? All right, angiotensin 2 also promotes sodium reabsorption in the proximal tubule, think ascending limb, and initial connecting tubule by direct effects, mostly through the sodium exchange dependent pathways. Okay, so is everything clear, you guys? Does that make sense? All right, I need to see another yes. Okay, perfect. Again, if any of you guys watching the recording after or the video on YouTube, please don't be hesitant to call me, email me, text me, anything, so I can clarify these concepts more if you guys find any difficulty. I'm going over them and nobody's having any difficulty, but if you find any difficulty, face any difficulty in the topic, please do not hesitate. Please do not hesitate to ask me. All right, I don't bite, I promise. I barely eat anyway. So the regulation of sodium and water reabsorption by hormones. Okay, now we have different locations, right? And the hormones that affect these locations and what they do. Okay, their effects. Okay, so in the proximal tubule, you have angiotensin 2 affecting and glucocorticoid. Again, remember what angiotensin do? It does, it increases the sodium and water reabsorption. We want these. Okay. Now in the thick ascending limb, you have aldosterone and ADH. Okay, and they want sodium. Okay, I don't know why Dr. Hashem put this. He didn't even explain it in the slide. But you guys remember what ADH does? It increases water only, no sodium. Okay, and now in the distal tubule and the collecting duct, you guys remember the natriuretic peptides and urodilatin. So the effects of aldosterone, sodium, and water. Okay, the natriuretic peptides are the total opposite. So they're all trying to increase water and sodium, but AMPs are like, no, I don't want to. Right? They're the balance between more water retention and sodium retention, okay, and absorption, and releasing and excreting sodium and water, okay, and prostaglandin, I hope I pronounced that right, and bradykinin also decrease, but it wasn't really mentioned much in the lecture. So the most important ones, okay, are AMPs, aldosterone, angiotensin 2, and ADH. Okay, I think I just saw a question. 1 second. Why does the ADH in thick ascending reabsorb NaCl, but the distal tubule ADH does? I'm not really sure. Well, the point is to reabsorb the water. Now, where that is, I think it was mentioned in another lecture. The exact places and spots where water is reabsorbed. I think it was in the first 2 lectures or 4 lectures, because Dr. Shams puts in 2. All right, so make sure to text me. It may have been the reason of why he put it. It may have been mentioned in previous lectures, but all you have to know is where these hormones affect and what they do. This is what Dr. Shams wants you to know. Now, getting into the details and whatever, he doesn't really care that much, right? But as you can see, even in that previous slide, 1 second, right? So he even mentioned by an unknown mechanism. Didn't really get into the details of what these possible mechanisms are. He just told you by unknown mechanism, right? It decreases the apical sodium hydrogen exchangers. okay, in the proximal tubule. Didn't really get into the details. So as long as you know where that hormone affects and what it does, the point of why, what's the point, okay, you should be all good, inshallah. I'll also provide you guys with a file of collected of questions with their explanations. If you guys find difficulty in these questions, even after reading the explanation, again, please do not hesitate to ask me, please. Okay, I'm gonna take all of this very, very quickly, Aslan, in third year renal. So I should revise it even more with you guys. Okay, so please do not hesitate to ask. All right. Now I think for the final slide, yes, don't get too excited. This is the final slide. This is a very simple slide. Again, it kind of reiterates the points we've mentioned. Angiotensin 2 is stimulated by renin. And if you guys remember, what stimulates renin release? Yalla, that's a question for you guys. What stimulates renin release? Okay, that is true. Yes, and more accurately, not GFR, but renal plasma flow and the perfusion. All right. Okay. So yeah, again, the location is a proximal tubule. It's all mentioned here. You know, again, increases NaCl. You know, I may have repeated the information a lot, but repetition is very important. For memorization, because this lecture also depends on memorization as well. But I'm trying to involve as much understanding in it as possible. Okay, aldosterone by angiotensin, so renin, right? Angiotensin, and that also affects aldosterone. Okay, so renin is released by the reasons we mentioned before, the hyponatremia or the reduction in renal perfusion. And so when renin is released, that releases angiotensin 2. When angiotensin 2 is released, that releases aldosterone. Okay, with the other effects that NaCl, water absorption, right? Now AMP balances all this out, right? So when the extracellular volume is increased, there's too much volume, we want to get rid of that. Okay, along with urodilatin, the natriuretic peptides, right? They want to get rid natriuretic. Okay, they not anti-diuretic hormone or diuretic hormone. They're natriuretic peptide. They want to get rid of that volume. Okay, so ADH is anti, AMP is atrial natriuretic peptide. I said natriuretic a lot, but yeah, the location is in the collecting duct. Aldosterone is the thick ascending limb and the distal tubule and collecting duct. Okay, and they in turn decrease water and sodium reabsorption and salt reabsorption. Sorry, right? Because where salt goes, water follows. Okay, now sympathetic nerves and whatever, decreased volume, that also wants to increase the water reabsorption. And it's the sympathetic pathway. Okay, can kind of assume that affects everything. Okay, not just one. Right? Dopamine, I don't know why the doctor mentioned it, but I guess keep it in mind. Right? It is just like the natriuretic peptides. And then finally, ADH. Okay. And then here it acts on the distal tubule collecting duct. There's not much understanding I can help you with. Here it's just memorization. So when when is ADH released? Another question for you guys. Think this is a hint. It wants to increase water reabsorption. So when would it be released? I mean, not necessarily thirst, but okay, sure, you're giving very political answers with thirst and dehydration, but since it wants to increase water reabsorption only water reabsorption, right? It is released when the blood is hyperosmolar. Remember, when there's too little pressure, so little extracellular volume, right? So increased osmolarity or decreased volume, right, cause for increased water. Because what benefit would ADH be or have if it increases water reabsorption and salt reabsorption? If the blood is hyperosmolar, relatively or ratio-wise, that doesn't do anything. useless. So, when osmolarity increases, ADH comes into play. Okay. Now, I know there's a lot of memorization, but this slide really, summarizes everything. Okay. Whoops. Just my OCD. Okay. So yeah, this is a cool slide. Always ask yourself why. We're trying to balance out osmolality and blood volume, and there are many ways to do that. Okay. So yeah, I've talked about everything. It's a simple lecture. Didn't take us much time. So do you guys have any questions? All clear? Do you promise that it's all clear? Okay, perfect. Sorry for the interruption that happened in the end. But yeah, hope you guys have a good time studying renal. It's very fun, right? Dr. Shams really emphasizes on what you should understand, gives you concepts, helps you from scratch basically. His notes are very, very helpful. So long as you know what he wants you to know, yeah. I will provide you with the more practice with the file, a whole file, not just because I don't want to just slide in 2 or 3 questions here, right? I want to give you guys everything with the explanation. So I'll provide you guys with a file with explanations. If you have any difficulty with that, please do ask me. Okay. So yeah, thank you for listening and good luck on your exam. Assalamu alaikum.